Thank you, and welcome to CHEO's EHR Journey Part 2, Influence and Value of Monitoring and Evaluation. The Pan-Canadian Change Management Network is pleased to present the fifth in a series of change management webinars. I'm going to get a few housekeeping items out of the way, starting with the notice that this webinar is being recorded and may be posted on Infoway's website. All participant lines are muted, so you will need to use the Q&A feature if you wish to ask a question. At this moment, I'll give you a minute to read the disclaimer on your own. My name is Barbara McCaffrey, and I'm from Alberta's Toward Optimized Practice and a member of the Pan-Canadian Change Management Network. I'm hosting today, and I would like to warmly welcome our panel of presenters from the Children's Hospital of Eastern Ontario, Erin McCauley, Anne-Marie Perron, and Casey Parker. Today's presentation objectives are to gain insight into how a large healthcare organization EHR journey is being supported by change management activities, and in particular, their approach to monitoring and evaluation to refine their approach to workflow analysis and integration, training, and communication. Also to elicit details from CHEO's continuous quality improvement approach that allows them to impact existing and new EHR users during a multi-phase implementation. In today's webinar, before we get to the presentation from Children's Hospital of Eastern Ontario, we will briefly introduce you to Canada Health Infoway, the Pan-Canadian Change Management Network, and the National Change Management Framework. To ask questions, please use the Q&A panel at the top of your WebEx screen by clicking on the drop-down arrow, selecting Q&A, and sending your question to all panelists throughout the presentation. The question and answer period will begin after the speakers have finished their presentations. Canada Health Infoway, sometimes referred to as Infoway, is a federally funded not-for-profit organization created in 2001 with a mission to foster and accelerate the development and adoption across Canada of electronic health information systems using compatible standards and communication technologies by building on existing initiatives and through collaborative relationships. Pan-Canadian Change Management Network, supported by Canada Health Infoway's clinical adoption team, is a grassroots collaborative of change leader enthusiasts from across the country sharing best practices and ideas since November 2009. The network facilitates a national community of practice for change management leaders involved in the implementation of electronic health solutions, providing an environment for discussion, networking, and knowledge sharing. It was founded to share experiences and identify common goals that address ongoing change management-related issues and concerns with e-health space across the provinces and territories. Change management working groups are formed on an as-needed basis to work on deliverables of the network and provide national expertise, insight, and input to shape change management strategies and outputs to accelerate adoption and benefits realization of health information and communication technologies and the electronic health record. The Pan-Canadian Change Management Network has developed an integrated framework for describing change management activities within the context of e-health projects that consists of these 6 core change management elements. More detailed information for each of these elements can be easily found within our online Pan-Canadian Change Management Network community via Infoway's corporate website. And you'll hear more about this when we cover resources at the end. The core elements of the framework are made up of governance and leadership, stakeholder engagement, communications, workflow analysis and integration, training and education, monitoring and evaluation. Having a national change management framework helps to proactively focus on these core and vital activities, aiming to minimize negative consequences. Through thoughtful contemplation of these undertakings, both in planning and execution, proactively considers users of e-health solutions and presents communication opportunities. It also supports the integration of technology into practice and overall supports people and their organizations as they transition from the current state to the newly desired state. This is the goal of the National Change Management Framework. Today's webinar will turn our attention to the monitoring and evaluation element in particular. Let me introduce the team at CHEO as they prepare to present. Karen McCauley is a Senior Business Systems Analyst with the Children's Hospital of Eastern Ontario. Karen's clinical background is a respiratory therapist with many years of experience from both sick kids and CHEO, where she spent many years providing direct clinical care to critically ill pediatric patients. In 2008, Karen transitioned from her role at the bedside and joined the IS team as co-chair eClin Doc Design Team, where she helped lead the team in building the inpatient electronic documentation system in Sunrise Clinical Manager for nurses and health professionals. Post-implementation, Karen became part of the support team, providing sustainability support for system optimizations, upgrades, training to new users, as well as support to the quality auditing process for electronic documentation. Through this experience, Karen has seen the importance of engaging clinicians in the development of the EMR and feels strongly that with the right tools, care and outcomes can be improved. She is continuing to apply these lessons learned as she leads the implementation of EPIC in the outpatient clinics. Karen is also an active member of the Professional Advisory Committee, where she provides system input and guidance on documentation-related issues, as well as health professionals practice. Casey Parker is a business system analyst with the Children's Hospital of Eastern Ontario and is the evaluation lead on both the ambulatory and MyChart projects. Casey has an extensive research background, ranging from managing clinical drug trials to systematic reviews and meta-analyses. Not only has she managed these types of projects, but she has also had the opportunity in contributing to the scientific design. In addition to her role as evaluation lead, she is also an operational and analytical report writer for CHEO's Lab Information System. And finally, Anne-Marie Perron is a business systems analyst with CHEO. Prior to joining CHEO, Anne-Marie was a change management consultant working in a variety of industries, including shared services, IT, and health. Over the years, she has realized that she was more passionate about her work in the health sector. She joined CHEO to be able to apply her change management expertise and experience. In addition to her role as business systems analyst, she is also the adoption and readiness lead. Anne-Marie is ProSci certified and is a believer in the power of collaborative transformation. So let's go to the team at CHEO from Ottawa.
Welcome, everybody, and thanks for joining us this afternoon for the webinar. This is Karen speaking, and I'm just going to kind of go through the first couple of slides just to give you an idea of who we are here at CHEO. And then we'll get into the kind of depth of the webinar and talk about the importance of monitoring and evaluation as you're implementing an electronic health record. So just a little bit about CHEO. We have over 6,000 admissions every year and over 7,000 surgeries that are done on site. Our ambulatory care clinics are quite busy with close to 175,000 ambulatory visits a year, and we have over 2,500 staff and clinicians that support our hospital. We also are an academic center, and we see over 2,000 students here every year. And we also have a strong research component and have a strong link to the Research Institute here in Ottawa. So a lot of kind of players help to provide care in the area that we service, which is really eastern and northern Ontario and western Quebec, including in the north, Nunavut. So just a little bit about our current kind of experience with EPIC. Back in 2000, we started with EPIC as part of our scheduling, admitting, and billing system, and implemented at that point and really started our partnership with EPIC back then. In 2010, we made the decision to go to electronic documentation with our inpatient implementation, focusing really on documentation from a nursing and health professional perspective. And then there was really many of the ancillary systems that are part of our IS department in all areas of the hospital, including the eMERGE, our radiology system, our surgical system, pharmacy, and health records. And of course, we do have still some paper documentation that's going on in the ambulatory clinics and in the inpatient areas. So there was a decision at one point to really amalgamate all of our information services and be under the umbrella of EPIC. Because we had already partnered with them, we were comfortable with the approach that they had, and so the decision was really made to go to one integrated system, with the vendor being EPIC. So in terms of the plan and how that was going to roll out, we're currently in the phase 1 of the project. And we've gone live with Beaker, which is EPIC's laboratory IS system. We did do an upgrade of our scheduling and admitting. So even though we had implemented in early 2000, there were many changes that needed to be implemented before we could move forward with the other phases of the project. So we did that upgrade of both the ADT cadence and billing system. And we're currently implementing our EPICare ambulatory module. The plan in the future for phase 2 would be go to inpatient, and we need to go up with the pharmacy system, which in EPIC is called Willow. That then is the foundation for which we would build the inpatient application, and then eMERGE and the health information management, so kind of the health records component would also be part of that phase 2 implementation. Phase 3 is really looking at the OR and anesthesia and the links there, as well as bringing on Beacon, which is the oncology application through EPIC. And then we're actually probably going to be doing an upgrade to 2014 prior to going to phase 2. At first we thought that that would happen at the end of phase 3, but we're going to try and fit that in sooner. So in terms of the waves that we would, that we're currently rolling out in our ambulatory implementation, we've kind of grouped the clinics into 4 different waves. So we've gone live with wave 1 and wave 2, and you can see that at CHEO we have many different specialties. So although we're implementing it in an outpatient setting, we're really having to deal with a lot of different disciplines and a lot of content. A lot of specialty content had to be developed to meet the needs of our end users. We're currently in the process of going live with our wave 3 clinics, and they're slated to go live at the end of this month, which is October 27th. And then we do have other clinics that are a little bit more complex in nature that we're going to bring on in the spring. So really what we wanted to talk about today was a little bit about the implementation process. And as you can see here, the kind of the theory of the life cycle of implementing an electronic health record, it looks pretty linear, where you go through the planning, the requirements definition, design, development, integrated testing, user acceptance, go live, and then post-implementation optimization. But what we found out in reality is really it's not a linear process, and really you're going back and forth between many of the steps in that process. a lot of times having to go through the design and development stage. When you get to that user acceptance, you're having to circle back and really change sometimes your design and continually develop. The kind of process that we want to focus on for this particular discussion is really around that post-implementation support and optimization.
So just looking here in terms of the specific context for the presentation, and this is Anne-Marie speaking, we want to talk about the importance of monitoring and evaluation, and more importantly, share some of the ideas and the changes we have made along the way. And we also want to talk about this concept that we're kind of in the process of moving forward with, which is creating a culture of continuous improvement, so that whatever was deployed at Go Live was really the beginning, and then as we move forward with using the system, we're learning from it and trying to make it better as we go. So when it came to our monitoring and evaluation activities, we had both qualitative activities and quantitative activities, and both activities really complemented each other to support our change management activities and determine what we needed to do to increase the level of adoption with the system. On the qualitative side, immediately after Go Live, we had these daily huddles with directors, managers, and super users to get the pulse on what was happening in the areas that were going live. These huddles were used to obtain input on issues that needed to be addressed. In some cases, we were trying to obtain some ideas on possible solutions to address those issues. And we were also providing some updates or feedback on things that were discussed since the last huddle. So these daily huddles happened for approximately 4 weeks after a Go Live date. After Go Live, so post-Go Live, we organize these formal check-ins with all the areas that were going live, so one per area, to take an opportunity to reflect on the deployment process and discuss ongoing issues that those clinical areas have. And I'll be giving more information on the next slide about how we designed those sessions. On the quantitative side, so immediately after Go Live, we were producing daily or weekly reports to give updates to managers and physician chiefs about the use of the systems, any trends we were seeing in terms of number of encounters that providers had opened and closed during that period, the number of orders that were placed, just really getting a sense of how the system was being used quickly after Go Live. Post-Go Live, we're monitoring at a much higher level in terms of key performance metrics, and more information about these metrics and what we were capturing will be presented in later slides. So here's a design that we use for those check-in sessions that we did approximately 3 to 6 months post-Go Live. So basically our agenda began with a reflection about the implementation process. So here are these sessions, and this agenda was really about from 90 minutes to 120 minutes, and that was about the right time that it took to go through these steps. And we also made sure that we invited all the members to participate. So basically, during that first part where we did a reflection about the implementation process, we were asking feedback on what we should start, stop, change, or continue doing with respect to the deployment of our EHR. We found these questions to be more valuable and practical than the typical or standard, what went well and what could we do better. By asking specifically what we should start, stop, change, or continue, we were soliciting some ideas and concrete actions that could be done as opposed to really just obtaining a view about how people felt the process went. So this is where we obtained some specific ideas on what could be done. After we'd gone through that discussion, we then took some time to review the list of issues that had been addressed by the team since that clinical area had gone live. And this was basically to remind the group about all the activities that we had done and the issues that we had addressed. And this allowed us to move forward with the rest of the discussion around prioritizing the outstanding issues, knowing that we had a track record of resolving many of the issues that they had since Go Live. And the last part of our check-in was just to have an open discussion about the impact of the EHR on patient safety. So we found these check-in sessions quite valuable for the following reasons. First one, they allowed the team to really hear firsthand from the end users how the whole implementation process went, and it also allowed the end users to kind of vent about the challenges that they had with the transition and knew that someone had been listening to them in a more formal way as opposed to some of the maybe hallway conversations that were happening immediately after go live. We also use these check-in sessions to start beginning the process of sharing that responsibility for continuous improvement between IS and the clinical areas. It also provided us with an opportunity to celebrate the accomplishments that were made since the implementation of the EHR and really thank everybody for, you know, kind of supporting the system, being engaged, and getting through that transition. And lastly, one of the things we wanted to do during these check-in sessions, or that we found valuable, was really help the clinical areas understand that the system not only was it a different way to document, but also changed the way that they needed to work in their clinical areas, and that those issues weren't necessarily issues with the electronic health record, but mostly changes that were required in terms of process improvements on their end, and that those that process would be owned by the clinical areas. So during these check-in sessions, there were some recurring themes that kept coming back. The first one was all the clinicians that were involved in the requirements gathering and design phase were mentioning that it was difficult for them to be able to provide us with those requirements when they couldn't really envision or know what that future system would look like or how those workflow would change. So although we were asking them questions to understand what the requirements might be, they would have appreciated having a better sense of, well, how different is it going to be for me, and what do you need to know? And maybe had I known we would be working that way, I would have told you something different about what we would need with the system. There was also this balance between, you know, being able to share that vision with them about how the system would look like by making sure that the system had sufficient specialty content to make the application more meaningful, useful, and efficient for them. So finding that balance of, you know, how much specialty-specific content would be available for them at Go Live versus what should be built after Go Live. And the other main theme that came out from these check-in sessions was making the training more relevant to clinicians prior to using the application with patients. And we'll share some of the ideas that we've done on these topics in the next few slides. So in terms of requirements gathering, what we did start doing based on that notion that the providers, although we were asking them for some requirements, didn't know what the system looked like, we started to train our SMEs, so our subject matter experts that were kind of a point person from each of the clinical areas to answer some of our questions and give us some of the requirements. So during these sessions, it wasn't like a full training session on the system, but it was really to expose them to the features and elements that they would need to be able to they would need to give us feedback so we could customize the system for them. We also changed the scheduling of our requirements gathering meetings to make them longer in duration, but have fewer of them spread over fewer weeks. So when we initially started, we had like weekly meetings that were about an hour, but what we found was that wasn't sufficient time to get into the meaningful discussions and get the requirements, so we suggested having more half-day sessions with our SMEs to be able to really get those requirements. Now you can imagine that asking for half days, especially with physicians, was something that was quite challenging, but we found a good way to kind of get buy-in or kind of get our next waves of users to understand that this was really the best way of going about it. So we actually had a video made using one of the physicians who had gone through the process and that expressed her challenges with meeting weekly, forgetting from one week to another what was discussed, trying to put these pieces together, and having this go over several weeks. And so she was really sharing that with her. Ideally, she would have preferred booking, you know, longer times but fewer times so that during that time she could really focus on answering her questions, providing us with the requirements, and making the links between all the discussions that were happening. So that was really useful to have, you know, a physician really talking to the other physicians and helping convince them that this was the best way to move forward. The other piece is, instead of focusing our requirements gathering on everything we could build in the system for them, we started our first requirements gathering session by asking them, you know, of everything that we should do, what's most important to you, and then we made sure that the requirements gathering really focused on some of those key things. So maybe the things we were building or focusing on the specialty were different, but this really helped us focus on what was key for the specialties, and it was different given the nature of their work. In terms of design and build, one of the things here that was important for us was having some rapid optimization. So that post-go-live period, as we were having some issues with some enhancement suggestions, we tried to implement some of those quite quickly to kind of establish that trust that, you know, this is just the beginning. We said we would improve as we go, and this is what we were doing. So this was a way to kind of establish that relationship from the beginning, that we were going to be there to improve as we went. We also encouraged teams to provide enhancement requests, and these we documented that we would use at the check-ins to say, okay, so since you've been using, you flagged all these enhancements, are they still relevant, and which one should we focus on moving forward? As Karen explained, because of the nature of our wave deployment, after we were done with one of the waves, many members of the team were moved to the next wave to start the requirements process then. But this created some anxiety for the areas that were live and thought that they didn't have access anymore to that support or those individuals to be able to share their ideas on how they would like to improve the system. So we kept one application coordinator that was really there to support all the clinics that had already gone live and focus on their enhancements and fixes. There were other suggestions that were given to us during these processes that we haven't had a chance to implement, so including formalizing that continuous improvement process and establishing a forum or more formal ways to allow sharing of ideas and common issues between all the clinical areas that have gone live. In terms of training, since our wave one, we have been building real training patients, so actually building patients in a training environment that were developed using information from real patients, so that when the physicians and other providers went, they could kind of more relate to the patient that they were using in the training system. And you can imagine with wave one, many of our specialty areas had to work with one or two single patients, and maybe one of them was a diabetes patient that had really nothing to do with their specialty, and that just made it much harder for them to make the training relevant. We also had these Thrive After Go Live sessions, which were focused on one specific topic, whether it was documenting, ordering, medications, sending message to other providers in the system, and these weren't mandatory, but providers who were struggling with those topics could sign up. And also just because of the nature of the different users that we had, we also started offering these book a trainer sessions where an individual user could just call up the training center and ask, I'm struggling with this issue. Can I meet with someone for half an hour or an hour to go through these issues and show me how to do this? Other suggestions that we've heard was ideally minimal training should have been provided before go live, and that after go live more training could be provided where the providers could put into context the training, having gone through it with some real patients and knowing what they need to focus on. We've also had some feedback of training the whole team, so the whole specialty area together. Our training approach was to train by roles, so all the physicians were trained together, all the nurses were trained together, and all the health professionals were trained together, but we said that although that was useful in some contexts, it would have been nice to have at least a training session with the whole team together to allow for some of the interactions and working through their workflows. Although we're still in a project mode, because we have some areas that have gone live, we needed to have a good support system in place to go through kind of that operational support. So what we've done is we had these super users, which were clinicians that were kind of dedicated for a part of their work week to be able to support their colleagues in using the system, so either reminding them of how certain things could be done or actually identifying some issues and bring them up to the information services team. So these super users were originally only intended to be there post-go live, but we've kind of made this more of an operational role, so we have these people physically available to support the clinical areas. After go live, our command center hours were quite extended, but it wasn't realistic after go live to really keep that extended support. So we started making our hours in line with kind of the regular business hours and allowed physicians to either submit issues via voicemail or sending us an email that we would respond to the next day. We also have these tip sheets which a training team developed, which included screenshots and how-tos on specific features in the system. The feedback we've heard on those was that, you know, a clinician wouldn't necessarily go on our intranet, try to find the tip sheet they need, and try to resolve their issue that way. They much prefer to call someone, get some support specifically on that issue. But what we've heard is from those super users, they found these useful in their role, and they were using them, and after they've helped a clinician with a particular question, would leave them with that relevant tip sheet so they would know what to do. So this kind of summarizes what we've done with our qualitative information, and I'll now pass it on to Casey, who's going to review from a quantitative evaluation perspective what we've done.
Perfect. Thanks, Anne-Marie. Okay, so in terms of our benefits of life evaluation, we have monitored 12 indicators, 10 being quantitative and 2 being qualitative. And these selected indicators stem from expectations and deliverables set by Infoway and our vendors, in this case Epic, a best practice and guidelines. And these indicators are also aligned with CHEO's strategic level indicators. So displayed here are the indicators mapped to Infoway's benefits evaluation framework. And the gray bubbles, I guess in this case they look blue, it's grouped by net focus domains related to, actually it speaks to the reasons why we're monitoring these indicators. So looking at the left, we have one fitting under the system information service quality and user satisfaction. In this case, it's our EHR Readiness Assessment Questionnaire. And going on to the second bubble, if you will, we have 5 indicators that fit under the improved office and clinic efficiency. For example, in this bubble, the first one, % result messages marks reviewed within 24 hours. And then going to the next one, we have 4 indicators that fall under improved capacity to assess performance, conduct quality improvement. And an example coming from here would be encounter cycle time, so check-in, check-out, and that's evaluated in hours and minutes. And lastly, we have 2 indicators in the approved patient access. And for example, we have % visits with a printed after visit summary. So the bubbles that have the red encasing, if you will, are our qualitative metrics, and these are what I'm going to be focusing on in the subsequent slides. So just in terms of methods for our EHR Readiness Assessment Questionnaire, we utilize REDCap, so our Research Electronic Data Capture software. And this software is actually housed in our clinical research unit, and it's actually commonly used within the hospital as well as across Canada for research and quality improvement purposes. So essentially, the Readiness Assessment Questionnaire was sent electronically to participants, so in our case, our end users. It was sent to the respective inboxes. The questionnaire was distributed about 5 weeks before go live and 3 months after go live. And this was repeated for each deployment wave. So to date, we have actually successfully completed 2 out of the 4 waves. So in terms of the questionnaire itself, so just going to the right, in terms of the questionnaire itself, it's comprised of 3 sections. The first section kind of speaks to the background, just to get to know who's actually filling out your questionnaire. So for example, the role they're in, the department, years of experience, and the computer sophistication. Section 2 is really the meat and potatoes of our questionnaire. It equates to about 57 questions in there. So essentially they rank on a scale from strongly agree to strongly disagree. We added an option of not applicable in certain scenarios. And within this respective section, there's 9 themes ranging from leadership, accountability, training, and going as far as usefulness and friendliness of the actual system itself. And the third section has 2 open text items in which it gives end users the opportunity to share concerns and benefits, anything they essentially haven't covered in the questionnaire. So again, it gives them a great opportunity on that front. So here are the key findings of our Readiness Assessment Questionnaire. And before I get into the details here, I just want to indicate that you have to read these results with caution, simply because we only collected the information 3 months post-go live. We anticipate it takes about 6 to 12 months to see a true reflection of end users. So we will repeat a questionnaire roughly around the year mark just to see the behavioral change from 3 to 12 months. So just looking at the result itself, looking at case for change, looking at that theme, 98% of our end users understand the reasons for implementing the EHR, including improving patient safety and quality of care. And that increased about 1.1% relative to pre. So looking at Epic EHR usefulness, the level of agreement decreased by 35% in that using the EHR for clinical documentation improved the quality of care they delivered to their patients. And in a few moments, I'll indicate what our patients feel in terms of that perspective. And on the flip side of things, in terms of the Epic EHR user friendliness and usability, their end users' level of agreement increased by 14% in that it was easy for them to remember how to perform tasks using the EHR. So in terms of the patient satisfaction, we engaged our patient family-centered care team. We added 19 questions, page insert into our existing patient satisfaction questionnaire, which you see displayed on the right-hand side. We collected 6 weeks before and 3 months after EHR implementation, so similar to the readiness assessment questionnaire timing. We ran it for a series of 5 weeks, and we sent it to all patients' families that completed a visit. So it's certainly representative in terms of what the patients think. So in terms of the interesting findings, patients and families have noticed their providers using a computer during their visit to enter notes, share information, and to look at test results. And patients and families did not notice a change in the attention they were actually receiving from their respective provider. And lastly, patients and families did not find a difference in the ease of talking to their provider. So just looking at the balance and comparing patient's perspective versus provider perspective, so the patients felt a change in the attention or ease of talking to the provider was great, but then the providers, on the other hand, did not feel comfortable. The quality of care was not the same. Perhaps they're having anxiety in terms of looking at the computer and kind of entering information and focusing on that. But again, we are going to evaluate patient satisfaction and so forth down the road to see a different, or sorry, not patient satisfaction, but provider satisfaction. Just so again, so we can see the behavioral change, as it's very critical. In terms of the next steps, we certainly need to distribute results more broadly in-house and externally, so we can learn from that. We're at the point where we're disseminating income results. We need to apply lessons learned. For example, assigning perhaps an individual level executive owner for each respective indicator to obtain buy-in and ownership to move things forward. And we need to adapt our workloads to improve quality metrics. So this is where, in the initial conversations at the change management, specifically Anne-Marie, and the evaluation teams, myself and others, work together to kind of come up with some activities to support the potential change and certainly engage others to help things move forward. And lastly, it's very critical to engage the stakeholders at every level because they need to understand the data at an intimate level. So ultimately, it will support change to actually sustain the system. So now I'm going to segue over to Anne-Marie.
So as we're moving forward with collecting the feedback about the system, on a regular basis, we need to make changes to that system to respond to that feedback that we're receiving. And this is all in hopes to make our adoption rates with this system even better. But changing the system as we go does present some challenges, including finding effective ways to keep users informed about those changes that are impacting them. But we don't want to be spamming them either with all these information about, changes that have been done to the system and some of them not being relevant to their workflows or their practice. So we want to find ways to be able to effectively share the information and maybe information to users that's more relevant to their day-to-day work. Also, we have learned that there's different types of learners and that, kind of our communities have different ways that they would like to have that information. So while some might be okay with receiving an email, reading it over, looking at a screenshot, others have noticed that, they would prefer someone to sit down with them or have this shared in one of their weekly team meetings or details like that. So we need to find ways to communicate, especially some of those important changes, and making sure that it is getting to our end users, and also so that they're aware that we are making improvements to the system and that we're trying to make it better for them. So although those challenges are true for us, we do believe that there's a lot of benefits in trying to push this culture of continuous improvement. So we have been communicating this message since the beginning, and I think at the beginning of the Wave 2 requirements gathering phase, we've been telling them that, you know, the system won't be perfect on day one. Let's try to get some things in there, let's have you play in the system, and let's improve as we go. We felt it was important to adopt this because it reduced the need to have perfection prior to go live, and remembering that we are working with high achievers and letting them know that the system won't be perfect on the get-go, and that we needed to have them start using the system and then improve based on the feedback they would provide us would be much easier. So we had to address this level of expectation, and we also had to put into place ways that they would trust that we were going to continuously improve. So some of those quick fixes we were doing, you know, documenting those issues, sharing that with them. By sharing this message of continuous improvement, we were also hoping to gain their trust and repeat the message that Go Live was really only the start date and not the end, and that we would continue to work with them. So this allowed the team to focus its efforts on fixing issues based on their priority and sharing those prioritization criteria we had with them. So for example, any issues flagged to us related to patient safety would likely be resolved first versus other more cosmetic or suggested changes that way. It also allowed the project team to pilot new functionality in certain areas as opposed to deploying it in all areas. And it also encouraged clinicians to be engaged by asking, okay, so if you're making this better, how can we make this better? And then suggest some different ideas to us to make it better as we go. So this kind of wraps up some of the content, and I'll just let Karen kind of close off where we're at and what we need to do next.
Thanks, Emery. So even though we're still in project mode and still kind of implementing Wave 3 and Wave 4, we recognize the fact that we really need to establish a culture of continuous improvement and get some things put in place to facilitate that process. And we're fortunate at CHEO to have really the organizational support to do that. So we recognize that we need to formalize a process where end users discuss and collaboratively agree on changes that need to be made. In talking to other centers, we realize that you can become quite reactive to requests, and people are kind of stopping you in the hall or calling the support center and asking for things that they feel would be an improvement to the system. So it's really about having them as a group discuss what changes would be most efficient for their group, and then kind of identifying that shortened list of optimization. The other benefit that we've seen is that there have been some clinic areas that have kind of taken on having these discussions at their team meetings. So we're really sharing that model with other groups to say, if you have kind of a dedicated agenda item related to the EHR, then you can really have those discussions about what's working well or what's not working well for your specific discipline, and then identify and be able to put some priority around what changes should be made first. In terms of really allowing the users to take ownership, we, as much as the project team is helping at the beginning to facilitate that requirements gathering and the design, we really want to start to push that back to the clinic areas and the teams to take ownership of those enhancement requests. So to really think about what's going to work for us in the electronic health record and what works organizationally, and what things do we want to really standardize versus customize. We do need to establish some type of a priority system for maybe scoring issues that come in so that we can really tease out what are the high priority items. As Anne-Marie suggested, we would really focus on those patient safety issues first, and then look at changes based on that scoring grid so that we can kind of have the biggest bang for the buck and make sure that we're making the changes that are going to have the biggest impact to the majority of the users in the system. And right now we don't necessarily have that framework solidified, so that's really where we're at in terms of kind of establishing a process so that we can have those changes optimized in the system in a kind of more formalized way. And also then formalizing the communication out and how do we use our key players like our super users and our training team to then communicate the changes in the system and make sure that people have the support at the bedside to kind of deal with the changes to the system, since we will always be improving and optimizing the system.
Thank you very much to Karen, Casey, and Anne-Marie. So now we are at the question and answer time of the presentation, and I would like to encourage participants to use the Q&A panel for that purpose. So the first question that we have is in relation to measurement. So have you seen a correlation between the key performance indicator measurements and improvements implemented based on your check-in sessions? So in other words, did the qualitative improvements also translate to higher quantitative benefits?
So this is Casey speaking. I'll take a stab at the question, if you will. Because we're in the beginning stages of monitoring KPIs, I don't think there's a direct correlation, but I certainly believe there's some degree of impact. The project team keeps the lines of communication open between end users, myself, and other stakeholders. But I do think over time, as the focus shifts from more core system build to optimization, and coupled with the fact that we need to determine how to best change existing workflows, there'll be a bigger impact and bigger correlation.
Thank you, Casey. Our next question is, how did you choose the clinicians to provide the feedback?
So this is Karen speaking. I think this was a key piece early on in the planning where we really identified the SMEs, which are our subject matter experts, and our physician leads. It was really about identifying people who were clear on the workflow and that knew how the clinic area functioned and what the requirements would be. Although there might have been interest from some more junior staff members in the area because they were interested in the electronic health record implementation, we really tried to choose people who had the experience in the area and could really talk to the workflows. They didn't have to know anything about computers or electronic health records, but really just about how things functioned within the area, and that was part of their daily task. And in some cases, we needed to circle back with just the physicians for some of the requirements because it was really specific to how they would order things. But in most cases, we tried to have the groups together when we did the requirements gathering sessions so that they could kind of really identify the requirements together and have some of those workflow discussions. So in most cases, it was the chief of the department that would identify the physician lead. And we have a very strong chief medical information officer, and he did a lot of lobbying with the physicians to kind of get that engagement early on. We also asked the managers to identify the subject matter experts and make sure that they would have the time to participate in the sessions. So they definitely had support from their managers to free them up to make them available for those requirements gathering pieces.
Thanks, Karen. The next question is, did you use any specific adoption evaluation framework or a framework to increase the adoption rate?
This is Anne-Marie. There are a few things that we did rely on. So we didn't necessarily stick with one model, but we did inspire ourselves from many models out there. In terms of that readiness and assessment, there were some tools available from Canada Health Infoway and their framework and some readiness questionnaires there. There was also, in terms of success factors related to the use of EHR, where we used a paper from Morton in 2008, and that reference could be shared later, but there was a paper where different elements, including EHR usefulness, EHR ease of use, details like that we kind of reused some of the questions from those readiness assessment questionnaires. And what we did is we kind of used those questions before go live, so while people were being trained to get their impressions at that time, and then after they use the system for a few months to get their impressions after that. So we could really compare if after more use of the system their adoption had increased or not. So we kind of developed our survey built on what things we were interested in, leveraging different models that were out there based on things we know we would do something about if we were going to measure them.
Thanks, Emery. And I think this next question is related to that, about that process for determining your criteria for measuring adoption.
Yeah, so I guess and this is possibly an area in terms of now, as we're moving more into operations, I think that will be one of our next steps, is how can we monitor the adoption in terms of the operation. So I think what we've done is we've monitored the adoption rate in terms of really close to go live with those models that I've just talked about. I think what we need to do now with some of the qualitative metrics that Casey, or quantitative metrics that Casey was presenting, that we need to look really at those metrics, which, as Casey explained, comes from our vendor, comes from some requirements from Infoway, and really to look at how do we monitor more for operational use and making sure that people are continuing to use the system effectively and efficiently, and then seeing what we need to do around there. So I think that's the stage where we're at now.
Thanks, Emery. The next question is, what patient safety criteria are being evaluated in your adoption program?
So this is Karen. In terms of patient safety, it was a bit difficult to evaluate things pre-go live just because everything was on paper. And what we're finding now is that we have a lot more valuable information post-implementation that we can use, to evaluate patient safety. One thing that we did leverage in those check-in sessions post-optimization were, after Wave 2, we added in some questions around patient safety, really asking areas in terms of if they felt that implementing the EMR improved or in any case may have contributed to improving patient safety or may have had a negative effect on patient safety. So we're kind of gathering those examples. We haven't really done a formal evaluation of them, but we're gathering that data right now. We also have a safety reporting system that we're encouraging people to use in terms of if they feel that for some reason that patient safety has been impacted, then they enter that into the in our SRS system and indicate that it might be due to documentation, and then we follow up to see if we can improve our workflows within EPIC or improve our training to meet the goal of improving patient safety. There are some areas that we really lock down within the EMR to kind of ensure that we maintain a strong patient safety environment, and those would be areas related to allergies, heights and weights, and medications. So although we go out and we gather requirements from the clinic areas, there are some sections that we just say that there are no modifications that we will make to those sections because of patient safety issues. We also look back to see what certain patient safety issues there may have been in the past and how we could modify content in the EMR to ensure that we just make things clearer to the end user.
The system also comes with a lot of auditing reports. So we've been kind of looking at those just to see or assess how the system works, but we haven't really gone yet into formalizing and auditing the practice of the use of the system. So those both the workflow issues that the system presents, but at the same time within the system, auditing the information for quality there as well. We know there are some reports, we've been looking at them a bit, but haven't gone to that full point of making those operationals and really following up, just to see a bit what has been going on with the system so far.
And I think certainly from the operations side of the house, they're seeing the value in now actually having data that they can follow up on with the users and ask, how come you place this order in this method? That's not really within your scope of practice. There are practice issues that we would not have been able to follow up on before that we can now because we are doing this reporting out of Epic.
Thank you very much. This will be the final question before we close off today. With respect to training, you make reference to learning styles, preferences, and types of users. What advice would you give change management and project support specialists that are new to working with physicians and clinical teams?
I think one of the first things, so initially, if we compare to Wave 1, which was maybe more of a generic approach, so we had kind of specific things on how to use the system that we were showing to the providers and the clinicians. Although we were showing those clinicians, like, this is how the system works, it seemed that if we weren't putting it into context of, okay, so this is an actual patient you might see and this is your workflow, it was, for some, quite hard to do that translation between, okay, so I know that those are all the buttons and I know what they do in the system, but when I'm back at my desk alone, how do I put those pieces of the puzzle together, and am I doing it right? So I think the key here, or the biggest feedback, would be the time spent on showing the functionality of the system should maybe be more minimal, kind of at a glance, this is what's possible, but then allowing for some time for either the providers to practice more specialty-specific scenarios with some real examples that are relevant to them. And I think what's important for us is, in addition to this training, just before go live, we kind of wrap things up with a dress rehearsal where we're going through some mock scenarios. So I think the more you can make it relevant, especially in an area where you have like specialists, I think that's important with respect to the training, that you try to respond to the needs of those specialists.
And I think the other feature that really had a strong impact was just having a play environment, so a sandbox environment where they could really get in, and some users weren't able to really grasp the concepts in training because it was just so broad, but they would go back and they would kind of work through those scenarios in our play environment. We didn't have that for Wave 1 as much, and we certainly saw the change that it allowed for Wave 2 and Wave 3. There were some users that just went through and practiced all of their workflows with their patients in the play environment, and then at Go Live were quite ready to go. They would not have done as well in the classroom because the pace is just a lot quicker with a lot more high-level information.
Thanks so much. And I see, looking at the time, that we're going to be getting ready to conclude our webinar shortly. Before we do that, I want to remind participants on the line that there are some change management resources available on the Canada Health Infoway website, including the framework and toolkit for managing eHealth change, people and processes. There is also an online toolkit repository, which has many offerings in it. And finally, I would like to invite change managers on the line to join us on our LinkedIn website and become a member of the Pan-Canadian Change Management Network. And as we prepare to close today, I wanted to very warmly and sincerely thank the team at Children's Hospital in Eastern Ontario, Karen, Casey, and Anne-Marie, for sharing with us today your experience and the ongoing journey that you have at CHEO in a very complex environment for implementing your EHR. So thank you very much.